All right, well, it's 8 o'clock and we'll get started. Today I'm very absolutely delighted to have Dr. Dee Ford as our guest speaker. Dr. Ford was raised in Anderson, South Carolina, and received her Bachelor's of Science degree from University of South Carolina, then completed her medical training and internal medicine residency at Johns Hopkins School of Medicine. She completed her pulmonary and critical care medicine fellowship at MUSC in 2005, and she remained there as faculty, has risen to the rank of full professor with tenure, and is currently the interim division chief of pulmonary and critical care medicine. She really stands out as a nationally recognized innovator in education and research with a unique niche in the development and evaluation of interdisciplinary programs in the areas of critical care, palliative care, and novel methods of critical care delivery, which has led to her interest in telemedicine. And looking through her CV and portfolio, she really is a great example of being able to leverage education and clinical activities into a robust research program. And if Dr. Ford was here, she would really be a role model for what we call the integrated pathway. She's assembled a true multidisciplinary research and education team with members from multiple schools, departments, discipline. She has an outstanding track record of mentorship, again, spanning high school students, junior faculty, physicians, nurses, dietitians, psychologists, etc., and has received the Department of Medicine Faculty Mentoring Award. She was instrumental in helping MUSC secure a multi-million-dollar award from the state to develop telehealth programs in order to improve the health of the communities throughout South Carolina. She leads the Tele-ICU program, again, aimed at improving critical care delivery to rural communities. And through that, she's developed a really cool and unique educational outreach program for critical care delivery, ICU Innovations. She also led and is the PI of MUSC's National Telehealth Center of Excellence funded by HRSA, and was the first one awarded. Mississippi came second. Really her program and efforts in the telemedicine and healthcare delivery space have been an inspiration to me and provided a blueprint of things that I would love to accomplish at Wisconsin. So with that, I will introduce Dr. Ford, who will be talking about innovations in telehealth to improve population outcomes. Thank you.
Great. Thank you, Lynn, for the very kind introduction, and thank you for having me in my office presenting medical grand rounds to you all in Wisconsin. I would love the opportunity someday to come and visit, perhaps in the summer when I suspect it's lovely there and hot and humid and gross here in Charleston. But I really am excited to get a chance to speak with you on some of the work that we're doing in telehealth here at MUSC to improve population outcomes. And by way of disclosures, I have no conflicts of interest relevant to this talk. My funding sources include the Health Resources and Services Administration and the National Institute of Health. And by way of objectives, I wanted to discuss with you some basic modes of telehealth delivery to articulate how, if you're interested in developing telehealth programs, you can create a tiered evaluation plan that would be aligned with the maturity of your telehealth program. Review some of the telehealth programs, largely ones that we have implemented here in South Carolina that are achieving population health impacts. And then, given the times we're in, towards the end, talk about how we applied a lot of our telehealth infrastructure in different ways to the COVID-19 pandemic. And so to kind of orient you to the fundamentals of telehealth modes and the growth of telehealth, I would start with this broad definition. What is telehealth? As defined by the American Telemedicine Association, it's the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. Well, that's a pretty broad definition. So to kind of give you some figures and some images to go with this, telehealth can include secure chat functions between providers and patients. These can be buttressed with home monitoring devices that can be tied into these applications. Here's a pulse oximeter shown. for use. In fact, we're using this with some of our COVID-19 remote patient monitoring population. I'll talk about that towards the conclusion. I think a lot of telehealth is using cart-based care delivery, connecting providers in one location to a patient and provider in another location. So for example, our school-based telehealth program, our Telestroke program, in fact, all of our telehealth services that are based in acute care hospitals, for the most part, use cart-based technologies shown here. A number of these carts, by the way, can have peripheral devices like stethoscopes and otoscopes attached to them with really excellent fidelity and ability to perform a remote physical exam. And then the program that I helped start and lead here at MUSC is a Tele-ICU program, which really falls under the auspices of continuous remote oversight. And in these situations, the providers are in central operations centers with multiple screens, as you see there. That's one of our Tele-ICU nurses monitoring many patients concurrently. And I'll spend a big amount of time on the Tele-ICU as a kind of model for telehealth program analysis. But to go a little bit further, I think this is kind of a nice way to break down different modes of telehealth and different intended recipients of telehealth. And broadly speaking, telehealth can be provider to patient, which I think is fairly intuitive. Video visits, patient-centered settings like nursing homes or jails. It can be shown here in the this box. It can be provider to provider. So we do a lot of that with our Telestroke consulting, for example, to emergency departments. Hospital monitoring would be Tele-ICU. There's opportunity for specialty care to primary care. These can be either synchronous or asynchronous, shown here, synchronous versus asynchronous. The remote patient monitoring and then e-consults are also provider to provider. And so there's a lot in here, and I won't go through every bit of it, but I hope that some of the examples I'll be featuring will help kind of bring home to you the role of the provider to provider, provider to patient, synchronous or asynchronous. Those are really, and then the timing, those are really the major categories to think through. And so I'll focus a lot on hospital monitoring because that's Tele-ICU. I'll talk about the hospital consulting, which my example here will be Telestroke. I'll highlight some of what we've done with school-based telehealth, which we consider a patient-centered care setting. And then towards the end, I'll talk about our COVID-19 remote patient monitoring program where patients are at home and we have a team of nurses helping support them here at MUSC. To give you a little bit of background on our own organization, as Lynn mentioned, we've got a fairly long history, 10 years, which I guess in telehealth might be considered lengthy, but our initial programs were very grassroots driven. Listed here are some of the early ones, and I was sort of part of this early journey. And they were really motivated by our attending physicians who saw needs in the rural community that were never going to be met locally due to scarce medical providers, and found different pathways to fund sort of startup telehealth services, if you will, grants, philanthropic, etc. And then, as Lynn mentioned, in 2013, our state legislature observed that we were, really doing pretty good work with this grassroots effort, and gave MUSC substantial funding to accelerate the growth of telehealth in our state to try to better mitigate some of the pretty substantial health disparities that we have here in South Carolina. And the legislature has annually awarded MUSC significant funding to continue this work. But it's not just about our organization. We were charged with starting a statewide program, which we have done in 2014, which we termed the South Carolina Telehealth Alliance, which has representation from stakeholders of other major health systems, our Department of Mental Health, our Medicaid office, etc. And then, as Lynn also mentioned, because of this work in 2017, the federal government designated us as one of 2 national telehealth centers of excellence. We are largely using those funds to continue to accelerate research in the telehealth space and to try to characterize and report out best practices. And then in 2019, we were fortunate to be awarded the American Telemedicine Association's Award for Transformation of Healthcare Delivery, and this was awarded to the South Carolina Telehealth Alliance. So it's been a really exciting and interesting journey in the telehealth space here at MUSC. But broadly, I think it would be very safe to say telehealth is on the rise, and this would have been a true statement had I made it in January. It's become even more the case now with some of the changes to reimbursement and the COVID pandemic. So you can see this sort of exponential increase starting in terms of telehealth usage in medical claims, starting really in 2015. And I don't think any of us perceive this to be something that's going to decrease in any way. It just has too many advantages for how we can improve care delivery. So if we were to think about an adoption innovation curve in the telehealth space, I think it would be safe to say that prior to 2010, you were really, if you were doing telehealth, you were probably in the innovator kind of range of the adoption innovation curve. I think from 2011 to 2020, I would probably characterize this as the early adopter phase. And I think with some of the changes we've seen from the federal level, at least, and from many commercial payers as relates to telehealth reimbursement, I think we're very quickly going to be hitting this early majority in the not distant future. To give you a little more sense of what we do here, at this point, or at least as of 2019, we had 119 unique services. We're in most counties in the state of South Carolina have almost 350 sites, a pretty heavy focus on acute care hospitals. We provide a lot of mental health and dietitian support to outpatient clinics, particularly rural clinics, 112 schools in the state, and 33 other types of facilities, including nursing homes and correctional facilities. But because so much of our focus has been on how do we address the needs in rural communities, we've had a very mission-grounded approach to this, where we focus on underserved areas. We sort of tally up all of this. 78% of our telehealth services are in completely or partially medically underserved areas in South Carolina. And what this map is highlighting is that the red are medically underserved areas, blue are non-medically underserved areas. Just to orient you to kind of where Charleston is, we're right here on the coast. This is the Atlantic Ocean, or would be if I were showing you that. But what this little pull out here is intended to illustrate is that even in areas like Charleston that are considered, urban and it would be considered, fairly affluent for a place like South Carolina. Even here, we have significant pockets in our county of medically underserved communities and disadvantaged populations. So that's really been, a very intentional and a very intentional part of our telehealth growth is how do we try to mitigate these health disparities. Show you some of what we've done that I think suggests we may be accomplishing that. So if we were to have a synopsis here, hopefully you've gleaned there are varied telehealth modes and recipient types and timing of telehealth care delivery. And I think this diversity of how to think through who needs what, when, where, and how really allows you to innovate. And so I think historically, telehealth was like, oh, we'll just replicate care over distance. You don't have a neurologist, we'll just send you one through a video conference. But really, we don't think about it that way anymore. And we think that's an antiquated way to view telehealth. In truth, our vision is that telehealth should be used to improve the efficiency and or the effectiveness of care, both for providers, patients, and health systems. And so when we think about a new telehealth service, we really try to think strategically about how would this improve the efficiency or the effectiveness of care, and is a telehealth solution really the right answer? So all of this sounds great, but I think it would be a very fair statement to say, well, how does telehealth, what are the outcomes? Show me the data. And so one of the big areas we're focusing on in the HRSA-funded Telehealth Center of Excellence is how do we apply rigorous scientific methodologies to think through truly demonstrating improved outcomes at the patient level associated with telehealth. And so one of the things we put a lot of thought in is that how do you align your telehealth evaluation with your telehealth program's maturity or stage of development? And so this is a busy slide that I'm going to show here, and I won't walk you through all of these things. Hopefully the slides will be available to you if you're interested in this at a later point. I'm certainly happy to provide them if not. But if you just sort of focus on those top four boxes, we really adapted some things from the National Quality Forum and the WHO, but we added, I think, a lot more granular detail about a telehealth measurement framework. And so even before you start your program, we call this pipeline, just thinking through feasibility. sort of recommend what that definition would be, what measurement domain should be, where your data sources might come, and what your quality management tools and or research study designs might be appropriate for this. So when you're sort of first thinking it through and doing a feasibility assessment, that's obviously quite different than by the time you're at what we termed stage 3, you've got a program that's well established, it's sustainable, you have scope, you have scale. But I would highlight, if you're sort of in this getting started phase, the pilot stage, a common, I guess I would call it error that we see programs try to make, is they're getting started with a pilot project that's at a single site, probably going to be a pretty small number of patients, and they're already wanting to try to get at things like cost effectiveness. Well, you're really not going to get at cost effectiveness until you're pretty far downstream in your evaluation. So the point of all of this really being mapping out your evaluation measures and your evaluation approach to the stage of telehealth program maturity. Otherwise, you're unlikely to demonstrate the outcomes you would like associated with where you are. So I'll use Tele-ICU as a case study for this applied measurement framework. And in part because it's the area I have the most knowledge about in telehealth in some ways, but also because it does have a fairly lengthy history of scientific publication. And I think it would be quite accurate to say that from 1998 to 2003, this was really sort of in the pilot testing mode, single center, before after trial designs, fairly small samples. But that pretty quickly evolved during the sort of early 2000s to where now Tele-ICU programs, in part because Tele-ICU is typically buttressed with really robust data that you can have access to just by the nature of how the programs are designed, started getting to effectiveness and what, improving different outcomes related to ICU patient care. And then moving forward, there was a lot of interest in the nuances. Some organizations demonstrated quote unquote positive outcomes and others really weren't. And so then folks recognize that a Tele-ICU is really a massive system change for an organization, and perhaps part of the implementation or uptake of the Tele-ICU could influence whether or not the program was driving an effectiveness. And I think I would certainly put myself in this camp. It is absolutely not something you just plug in and you're kind of good to go. And so that's kind of where we were here. And now I think the field is really wanting to understand, how do we optimize the Tele-ICU delivery so that you're capitalizing on the investment and you're optimizing the potential for positive patient outcomes. And so I'll walk through some studies that I think kind of highlight this concept for you. Just in the interest of time, I will not really focus on the early pilot projects. And, unfortunately, I also really won't focus so much on adoption and driving uptake, but I will share with you some of the studies that I think illustrate effectiveness outcomes and then optimization, which has been some of the work we've tried to focus on with our own program. And so just to get a sense of what are the core elements of Tele-ICU, it really seeks to use technology to leverage the limited professional resources for ICU population health. So this is not a consult-driven mode. This is continuous oversight, responding to acute patient situations, assessing every patient admitted to the ICU that's in the program to make sure you're looking through best practices, et cetera. So it is continuous remote oversight. I've mentioned it has robust data collection and analytic support with reporting outcomes associated with it. A lot of quality monitoring, it goes into this, looking at adherence to certain ICU best practices, as well as hospital level factors, such as do you monitor too many patients in your ICU that are relatively low risk, as one example, sort of financial quality monitoring, I guess we could term that. And then there are a lot of reporting in terms of process and outcome measures specific to ICU patient populations, as well as things like length of stay and financial performance. So that's kind of a snapshot of what these programs look like. It's a remote multidisciplinary team as well, by the way. It's not just the intensivist. We've got critical care nurses, advanced practice providers, respiratory therapists, all working in operations centers supporting the ICUs that are in the program. The big driver for Tele-ICU, frankly, has been the pretty well-established national intensivist physician shortage. And that combined with the fact that the Leapfrog consortium has recommended intensivist staffing as one key strategy hospitals should implement to improve the quality and the value of patient care that they offer. And so shown here from quite some time ago now was the adherence with the Leapfrog intensivist staffing recommendations in the United States. So what this, to meet this metric, what your institution would need to offer is either co-management with an intensivist of all ICU patients, or a quote closed ICU where the intensivist is the primary attending of record, and furthermore that physician should not have any other significant clinical responsibilities when they are rounding in the ICU. So if you use those standards, almost half of our US hospitals had none. About 20% had some kind of intensivist availability, and only really 20% met this pretty rigorous standard for intensivist oversight. So that really became one of the main drivers for hospitals to adopt Tele-ICU services, because that would allow them to have access to this intensivist oversight. And then that desire compounded with a predicted intensivist shortage that I think certainly we feel here even at MUSC, but very much feel broadly in South Carolina. These two things combined have really been a big driver for the demand for Tele-ICU. And then over the years, in terms of effectiveness, there have been quite a number of studies that have shown different types of effectiveness listed here. So in terms of clinical outcomes, reduced ICU and hospital mortality, fewer complications, fewer errors, better adherence to ICU protocols. There's, as I mentioned, financial metrics that we track, such as length of stay, for community hospitals in particular, being able to retain certain patients that they may have otherwise transferred, better throughput, higher acuity, largely driven through hospital CMI indices. And then strategically, many hospitals feel that it helps them recruit and retain ICU staff, largely via reduced ICU nurse turnover, sometimes through increased physician retention, because there's now kind of a pop-off valve so that they're not continuously on call, and then improved reputation in the community and better adherence to the Leapfrog recommendations for intensivist staffing. So over time, I think a number of pretty well-conducted studies have shown different types of improved effectiveness associated with Tele-ICU. But there's some nuance here. So this was a large retrospective study that used Medicare data and then matched it with Tele-ICU adoption data, and was able to identify 132 adopters to be compared to 389 non-adopters, and the main outcome was hospital mortality. And so when I say there's nuance in the effectiveness you can achieve with Tele-ICU, that's really what's highlighted here. So you see here the change in adjusted hospital mortality after Tele-ICU adoption. So below 1 being good, above 1 being bad. And these were the hospital ranks in terms of improved mortality after Tele-ICU adoption. And so what this really highlights is if you take sort of this dashed line here to be sort of your break even, sure, quite a lot of places did indeed see a reduction in mortality, but some saw an increase in mortality. Now, overall, and if you aggregate all of this, the outcome trended towards favorable, but what this is really highlighting, I think, is that there is quite a lot of variability in the kinds of effectiveness outcomes you'll see associated with Tele-ICU, which to me really highlights the need to understand optimization in a very meaningful way. And then finally, in terms of Tele-ICU effectiveness, the Agency for Healthcare Research and Quality conducted a systematic review of Tele-ICU programs, which included 22 studies in total. And their main outcome was that, indeed, it would appear Tele-ICUs overall are associated with reduced both ICU and hospital mortality. But as far as economic outcomes or adverse effects, and at least in the systematic review, there was insufficient data. And of course, not surprisingly, there were a major limitation here was heterogeneity of the studies included. So I think in sort of summing up the effectiveness question, I think there is now reasonable consensus that Tele-ICU is an effective way to improve patient outcomes, among other important outcomes in the ICU setting. But the question is, how do we optimize this? And so now I'll highlight some of what we've done to try to think about are we optimizing it here in the state of South Carolina? And so in terms of health disparities, we have, broadly speaking, a very substantial physician shortage in our state, and it's certainly a critical care physician shortage as well. So we are ranked 38 in the United States for active physicians per 100,000 population. For critical care specifically, we have one physician per almost 45,000. For pulmonary medicine, we have one physician per almost 71,000 per physician. So really a very significant gap generally for physicians for our state, and certainly for specialists in pulmonary critical care medicine. And that was really the motivation for helping to start MUSC's Tele-ICU. And this just kind of highlights sort of where we are. We started this program in 2015. Since that time, and these are just the different, shown here, the different hospitals that we work with. We've monitored over 35,000 patients with an estimated over 1,000 lives saved. This estimation, by the way, is adjusted for Apache 4B, so we report this as observed versus expected outcomes. And just as I go into some of our other specific programs here in South Carolina, I oriented you that this is generally where Charleston is. This sort of central portion of our state has particularly burdensome health disparities in South Carolina. Just really, really, really rough. Almost no doctors in some of these counties, no hospitals in some of these counties. And so we've done a lot of our work really focusing on the communities here specifically. And that kind of becomes relevant as we start to talk a little bit about the COVID pandemic. So the question we wanted to ask, Tele-ICU is an expensive program, it's very resource intense, and we wanted to understand, are our rural hospitals and is our state getting value for these investments? Value defined as the quality of care, meaning the outcomes plus the patient experience, relative to direct and indirect costs. And we applied a business framework, actually something called the Balanced Scorecard Framework, to try to understand the Tele-ICU value proposition for South Carolina. And what the Balanced Scorecard Framework holds is that not a single type of measure is kind of the definitive measure, but you should really try to have a composite assessment using multiple data sources and data types to understand the value proposition. We used, at this time, we used 4 of our hospitals because we wanted sites that had at least a year's experience with the program. We used observational mixed methods designed with multiple data sources, which include qualitative interviews with key stakeholders at our partner hospitals using a structured interview guide, as well as the really robust quantitative data that you get as part of your Tele-ICU outputs, including quarterly reports, volumes, etc. And so when we took, in addition to the primary data, we also conducted literature review to see what are the big domains of outcomes that people have reported on associated with Tele-ICU. And so the major domains we identified included organizational characteristics, clinical, financial, and strategic. Shown here are the operational definitions, and then just some examples of what that can look like. So organizational characteristics, for example, included physician leadership. Clinical, pretty intuitive, things like mortality. Financial, increasing ICU patient volumes, reducing ICU length of stay as examples. And then strategic, things like physician recruitment and retention, for example. We had a different number of measures in each of these domains, and we had different data sources for each of those measures. And so we essentially created a scorecard using the Balanced Scorecard Framework. And that's what's shown here. And so these don't necessarily add up to 100, nor are they meant to, because each of the domains had a different number of measures. We just divided them evenly. We gave them point values for the different measures, and sort of just created a summation of all of this. And what this is intended to highlight is that of our 4 hospitals labeled here as site A through D, you see that indeed all of the sites got some value for it, but there is very significant variation in the amount of, quote, value our hospitals were seeing at this time, at least associated with Tele-ICU. So to us, this is really highlighting the imperative to understand why site D, with a significant investment to be able to have access to this program, is achieving perhaps half the value of site A. And so this is really driving how we try to think through optimization of the program. And just interestingly, the qualitative factors, so things like physician buy-in and physician leadership, are absolute drivers of the quantitative outcomes. So better clinical and financial metrics, for one example. And so to me, that was just a really important take-home point that it is imperative to have the effective working relationships and leadership at the local level to be able to bring high quality care delivery through Tele-ICU. And so that sort of is where we're thinking through this now. So if we were to summarize again, just to remind you, the sort of pathway for telehealth outcomes research, starting with pilot testing, effectiveness, adoption in drivers, and optimization, sort of being, I think, a fairly reasonable approach to that. So at this point, I'm going to switch gears now. I'm going to tell you about a couple of our other programs that are associated with population health outcomes. And I'm going to start with our acute ischemic stroke service, which was one of our initial programs started in 2005. This is really relevant for South Carolina. Shown in the sort of US map here is stroke death rates, the darker colors being the worst. You can see here in the Southeast, it's a major issue. It's the third leading cause of death in South Carolina. And because health disparities is a focus for us, in our state, African Americans are 53% more likely to die than whites. Most of our state's population live more than 100 miles from a primary stroke center. We know that time is brain and stroke. So this program started in 2008. We had 5 hospitals. There were 87 consults. There were no South Carolina primary stroke centers. By the end of fiscal year 19, we had 32 hospitals in the state. We had conducted over 5,400 consults that year. We work with the partner sites to help them get Joint Commission certified to be a primary stroke center. We have 15 of those now. The average response time from the teleneurologist is about 5 minutes from activation. And I would highlight these 5,400 consults weren't all acute ischemic strokes. About half of the consults in a given year end up having an acute ischemic stroke, just as a little FYI. And so the stroke program really closely monitors key process measures to trying to achieve this pivotal process measure shown here on the far right, the door to needle time. So you can see on the left are the years from 2008 up to 2019. And really the point here is the program progressively just driving down that door to needle time for patients with acute ischemic stroke through telemedicine. And here in 2019, now down to under an hour. So because the Telestroke program has wide scope, wide scale, and pretty large volumes, we thought we could apply some population health approaches and epidemiologic analytic approaches to this program. And so we conducted a retrospective cohort study. We used all payer South Carolina hospital discharge data from 2013 to 2016. And our cohort were hospitalized patients who had a primary diagnosis of acute ischemic stroke in these study years. There's almost 40,000 patients that met this criterion. And the way we stratified this larger population is we compared the group that would have had telestroke access to those that would not have had telestroke access as defined by the patient county of residence. Because we know, of course, where our telestroke sites are. And so we had about almost 30,000 that would have had theoretical access to telestroke and about 12,000 that would not have during the study period. Just to contextualize this, of these 39,000 patients during that same time period, we only had about 4,000 that actually had a telestroke consult who also had a diagnosis of acute ischemic stroke in that same time period. So at most, our stroke providers could have seen maybe 10% of this total cohort. We also looked at process measures, use of TPA and endovascular thrombectomy, and our main outcome was in-hospital mortality and discharge destination. So these are really the main results of this analysis. And so at a population level, what we demonstrated is that if you were a South Carolinian with an acute ischemic stroke who had access to telestroke, you were more likely to receive TPA, more likely to receive EBT, less likely to die in the hospital, more likely to be discharged to an independent rehabilitation facility, and less likely to be discharged to a nursing home. So we really feel that, at least by association, the Telestroke program is associated with pretty significant population health outcomes. And we speculate that a lot of this is because not just the direct result of the clinical intervention that's occurring through that telestroke cart, but the education and training that we do for EMS, the training we do in EDs, this sort of halo effect, if you will, that we believe telehealth can be associated with. Now I'll show you example number 2 for population health outcomes associated with telehealth services, which is our school-based telehealth program and asthma care. So MUSC's school-based program provides both acute care for kids, such as, for example, ear infections, as well as chronic disease management, and in particular for asthma and ADHD care. And now, as I mentioned, 112 schools in the state. This is a cart-based program. This is highlighting one of our nurse practitioners here at MUSC and one of the school nurses that she's working with to evaluate this child. And the school nurse, as you can see, is using a stethoscope to listen to the child, and then our provider gets really excellent audio here to be able to hear what this person is hearing through this peripheral device, just as a little FYI. And so the people that led and developed the implementation of this program wanted to use what she termed, Dr. Katie King termed, a precision public health approach. And so she worked with some of our epidemiologists and said, well, where are the highest rates for pediatric ED visits for asthma? And those are the counties that I want to go and talk to those school boards and see if they'll let me implement an asthma-focused school-based telehealth program. And so the red and orange colors represent higher rates of ED visits for kids with asthma between those particular study years. And you may recall I mentioned that this is a section of our state that has particularly bad health disparities. And so she really started here in these counties with the highest rates of pediatric visits for asthma. And so we had an opportunity to conduct a sort of a natural experiment, if you will, again, using archival data to look at population outcomes. And so Williamsburg County had 100% of its schools participating in the school-based telehealth program, shown here in red. And then we had the surrounding counties, which are demographically and socioeconomically very similar, did not have school-based telehealth at the time. So we had this opportunity to compare a county level with full school-based telehealth uptake to surrounding communities that at this time had none. And so our population were children under the age of 18 enrolled in South Carolina Medicaid with a diagnosis of asthma. And we looked at the years 2012 to 2017, included young children because Williamsburg has startup programs, and so very young children can be enrolled in the school-based telehealth program. And the measures that we included were enrollment status, demographics, and primary and secondary diagnoses from a Medicaid database. And what we found is that the school-based telehealth program was associated with a significant reduction in ED visits in Williamsburg County, South Carolina. Overall, there was an almost 7% reduction in ED visits among children in this county. But what was kind of interesting to us, and I think highlights the concept of program maturity and program outcomes being really important to think through, is that in 2014, this reduction was about 4%. 2015, it was 6%. By 2016, it was down to 11%. And so the point here is that if you think that you go into a rural community and put a cart in a school nurse's office in that rural school, that the community is just going to embrace you with open arms, that's really not how this works. So the community and the schools themselves really have to come to accept the care delivery you're trying to offer to be able to sort of drive forward these improvements and outcomes. So if I were to summarize this, I think Tele-ICU offers an illustrative example of the evolution of scientific evaluation in telehealth, driving from piloting to effectiveness outcomes to understanding adoption and uptake, and then finally to how to optimize the service. And that I think it is a correct statement to say strategically deployed telehealth service can be associated with population level outcomes. But this takes time, it takes scale, and it takes scope. So now I'm going to switch gears. I know this is a whirlwind tour of a lot of aspects of telehealth, but I really felt like I would be remiss to not highlight some of the work that we've been doing as part of our telehealth response to the COVID-19 pandemic. And so over the years I've given talks on telehealth, I sometimes will highlight a lot of the different barriers that you can encounter when you're trying to start a telehealth program. I think one of the biggest ones, frankly, has been reimbursement over the years. But an interesting thing happened. The COVID pandemic happened, and a lot of those barriers have been just completely coming down, particularly at the federal level. And some really important barriers that have been lifted as part of the federal government's response to the pandemic have included CMS lifting restrictions on the types of providers that can do telehealth, the originating site and site of service, the types of services, the fees paid, as well as barriers on federally qualified health centers and rural health clinics being able to offer telehealth. And these restrictions from the CMS level have been extended for now until the end of July almost. They're sort of doing this on a month-to-month basis at the moment. And a lot of states have come up with similar changes to their own restrictions, so broadening patient populations and coverage for telehealth, as well as eligible providers and practitioners. Another restriction that's been lifted, although we think is likely to get put back into place, is the need for HIPAA-compliant technology. So I would absolutely not advise, for example, using FaceTime for telehealth interactions. There are many other alternative platforms. And the commercial insurers have followed suit. This is highlighting changes in Tennessee, where they're planning, Blue Cross Blue Shield is planning to make their telehealth benefits permanent. Our local Blue Cross in South Carolina has been extending it on a month-to-month basis, tracking along with CMS. And so what we did a variety of things, both in terms of telehealth as well as partnership with our biomedical informatics team, to create a COVID-19 dashboard, just showing you here a screenshot of that. It focuses both on outpatients, inpatients, patients being tested, virtual visits that are occurring, etc. And the big programs we started as part of our pandemic response included creating a virtual urgent care COVID-19 screening pathway, developing a COVID-19 remote patient monitoring program for those diagnosed with the disease, but who do not need to be in the hospital, but do perhaps need care and oversight in the home setting, using telehealth to minimize healthcare worker exposure, finally converting our ambulatory mission largely to ambulatory video visits, which is where we are really presently today. So the virtual urgent care program. So for those who may not be familiar, this is a virtual version of a doc in a box, meaning it was historically meant for low-risk patient populations with low-risk diagnoses, such as URIs. The particular tool that we use, the platform that we use, and I think this is quite pervasive, would historically have screened out someone that said, oh, I have shortness of breath, or if you had a chronic condition. So we really had to re-engineer our template that we use for the virtual urgent care to be able to include those patient populations, because MUSC's plan, and frankly the state's plan, was really to try to drive patients with symptoms of COVID to a virtual urgent care platform rather than an ED or a primary care office or other places where they could potentially expose patients and healthcare workers. And so that's what we did. We redesigned it specific to COVID-19 symptoms, and then have a pathway for the patient to be referred for COVID testing should they sort of screen positive, so to speak, on the symptoms. These, so this is kind of where we are. This is where we were as of April. I apologize, I've not had an opportunity to update these numbers yet. But between March 6th and sort of mid-April, we had screened almost 40,000 patients for COVID-19. We referred about 13,000 for testing. You can see here, this is really kind of where our patients were coming from. So we have a rural health network in this section of the state, and then we're kind of here. So largely, you know, our own patient populations, but really some degree of reach kind of along the coast and elsewhere in South Carolina. And then what we were finding at this time is we did almost 11,000 of those COVID tests at MUSC. We're having about a 5% positive rate. Now what's happened over time is the virtual urgent care screening volumes have gone down. This is from early March. This is just from June 2nd shown here. So, you know, there's a lot of utilization, and then the different social distancing and sort of shutdown restrictions were put into place during this time window. It'll be interesting to see what happens if I were to give this talk in July, because as we've relaxed many of the restrictions at a governmental level that had been put into place, we're really now starting to see this go back up in terms of virtual urgent care screening, and also individuals being diagnosed with COVID. So the story is, I think, far from finished. But one of the challenges, as I mentioned, we have sections of our state that have significant health disparities. So at least until literally this week, these were really our state's hotspots for COVID-19. You'll notice a similarity with the same section of the state that has all those health disparities. And then here we are, just to remind you, down here in Charleston again. And so our rural communities were not able to effectively access COVID testing. So what we've done as of about 4 weeks ago is worked with our legislature to get funding to establish pop-up testing tents in these hotspots, many of which are rural and underserved communities. So now we've sort of tied together expanded testing with the virtual urgent platform. And stars are highlighting where we have these testing tents, so that we can try to help continue to fulfill the mission of supporting or trying to mitigate health disparities. I'll switch gears now and talk about the COVID-19 remote patient monitoring program. So this is for outpatients who test positive. So the way we're handling this internally is that if a patient tests positive, that result, our virtual urgent care note, if you will, flows into our electronic health record. We use Epic. The patient can then get tested. If they test positive for COVID-19 and are an outpatient, that flows into a COVID-19 patient dashboard. We then have a team of nurses that call the patient to tell them their results and then offer them an opportunity to enroll in the remote patient monitoring program. We offer it to anyone who tests positive. And what the program provides is clinical oversight, education, and emotional support for people who have been given what can be a pretty concerning diagnosis. And what that tool looks like is we adapted a community-acquired pneumonia tool to have a patient-reported outcome assessment. And that tool really has some very great questions on dyspnea and shortness of breath, which I think would be kind of red flags for most of us clinically in the COVID cases. And then we do have a very small subset we offer home pulse oximetry to, shown here as one of the devices that we're using. And we have a team of nurses every day that looks through their dashboard, and any change in the patient-reported outcome tool prompts a call from the nurse, which can be pretty quickly escalated to a video visit with either the nurse or the physicians who back up the nurses. And we really feel like this enables more timely, urgent assessment if needed through referral to the emergency department. So as of program go live at the end of March, we had almost 500 enrolled in the registry. We had enrolled in mid-April only 111 patients. I will tell you, I got updated data yesterday. We now have enrolled over 500 patients in the remote patient monitoring program. We don't keep them in, of course, in perpetuity. As their symptoms resolve, we disenroll them because they don't need us anymore. And by mid-April, we had referred 14 patients for physician review. 9 of them had video visits, a couple of doctor phone calls, and some patients referred to the ED. These numbers have, of course, gone up over time. And then the healthcare worker exposure and personal protective use. So what we did for this program is we have had a telesitter program here at MUSC, where we have a monitoring station with remote patient sitters who monitor up to 8 patients on any given shift per sitter. And it's really largely was intended to reduce fall risk. And so they have a workflow where they can escalate concerns to the charge nurse, they can redirect the patient to get back into bed, etc. They've observed it really to be, at least internally, associated with significant reduction in patient falls. But the advantages of the technology this program uses is that it's simple, it's user-friendly, and it is very secure because the telesitters are using continuous audio-visual technology, which includes a cart that's in the patient's room, and then shown here this monitor that you can use to call into the cart. And so if you're a healthcare worker, what we did is we put the carts in our COVID patient rooms or in our rooms for PUIs. We also have these carts installed in our COVID cohort areas of the hospital. And so if you're someone that wants to contact the patient or someone that's in that patient's room, essentially it's like an iPhone. It's got a touch screen, you click the green button, you highlight which cart you want to go to, and you dial in and you're communicating with the patient and or whomever is in the room at the time, and with really high quality fidelity communication. And so what we have found is that so with installing the carts in the patient rooms, we put these monitors, by the way, at the nursing stations in these different areas. And we also have telehealth delivery pods in a section of the hospital. So we put those in for consultants potentially to be able to access communication with the patient at distance. And interestingly, this has been a big win for our healthcare workers. This is updated data. We've had over 8,600 calls to date. These calls average about 15 minutes. It's also been associated with significant reductions in PPE use. We did a small analysis, both the cost of the PPE as well as staff time to don and doff. It's already saved hundreds of thousands of dollars, we predict, for the institution. And so this was kind of in April. We kind of had a bolus of patients that were here in the hospital. We really never ended up with a big surge in Charleston, although that's actually changing at the moment. And then it sort of tailed down as our patient volumes in the hospital tailed down. And then finally, to touch on ambulatory and how we've used telehealth to sustain the ambulatory operations as part of our COVID-19 response. So nationally, it was reported, and I'm sure you've seen this in Wisconsin, that ambulatory visits just plunged, shown here, this being early March up into mid-April, as patients wanted to stay at home, as lockdown orders went into place, as we all were concerned about safety, etc. And so we really were charged with converting our telehealth operations to telehealth ambulatory operations. We use a couple of different platforms. There's a functionality in our version of Epic where you can do video visits right in Epic. We also have a HIPAA compliant platform that we use, Doxy.me, that actually was developed internally. But these were really our two main technological platforms that we've used. Presently, really the institution has guided folks to use Doxy.me. It has a lot of sort of ease of use that isn't necessarily available in the Epic video visit function. So if you were to take that figure that I just showed you that showed this kind of plummet in ambulatory visits, really what we've been able to help support over time is we saw the black dots here show MUSC ambulatory volumes. You see we had the same plummet. We've really had a bit of a better recovery, largely because of our uptake of telehealth than what's been seen nationally. Just to give you perspective, pre-pandemic, we would have about 5,000 ambulatory visits a day. And where we are now, these are as of the end of May at least, we have our ambulatory volumes up to 80% of pre-pandemic levels, really across the board. And this is overwhelmingly because of offering virtual care and telehealth visits. And then certain subgroups actually are using this for a growth opportunity. They're already we're pulmonaries at 100%. We're at full capacity already. Infectious disease and mental health are actually exceeding their pre-pandemic ambulatory visit volumes using video visits. And then we also really worked hard to support our federally qualified health centers, rural clinics, or Department of Mental Health. So in this particular type of populations, in a single 48-hour period, we enrolled about 150 providers. We enrolled at MUSC about 3,000 providers over a several-day period to try to really accelerate ambulatory care in the context of the COVID-19 pandemic. So I think lessons learned, many conditions can be managed with telehealth. We thought that before, but really continue to reimagine what that can look like. And at least from a patient-facing side, infrastructure turns out to be widely available since so many people have smartphones in this era. Having done all of this COVID-19 response in just a few months, what we would have considered to have taken probably a year or more, or even years prior to the pandemic, I think we've really internalized that things like logistics, training, staffing, and workflow can really be rapidly assembled and deployed. And we have had absolutely no resistance of any meaningful sort from patients. They really see it as protective. They find it more convenient. It's really been a win. And providers who have historically been a source of challenge in terms of uptake have absolutely embraced this. I will tell you, our first provider in the pulmonary division who really embraced the video visits, was one of our most senior ambulatory physicians, who would in no way designate himself as technology savvy, but he is. I'm not sure we're ever getting him back in the clinic in person, because he's had such embrace of telehealth. And I also just want to reemphasize, a number of restrictive regulations are now reduced. So things like interstate licensure, data confidentiality, and reimbursement have all really lowered the barriers to telehealth uptake. And then finally, what we're now looking at is, as our institution seeks to move into recovery phase, how do we use telehealth not just to recover, but to grow? And now that we can really extend our reach, because geography is increasingly irrelevant, how do we think about accessing, growing our transplant population, growing some of our very tertiary and quaternary care services through the state and through the region because of telehealth. And so that's really kind of our next phase, I think, of where we're going to go with all of this. So really, I think this is my last slide. I really appreciate the opportunity to talk with you about the work that we've been doing, and I'm happy to take a few questions if there are any.
Great. Well, thank you, Dr. Ford. That was an amazing overview of telemedicine in South Carolina, and really just shows how you can harness a technology to improve population health when you think about it strategically. And I wanted to ask, you talked about, for example, in the school-based programs, the importance of getting stakeholder engagement and input. Can you talk about some of the things that you did to ensure you have appropriate stakeholder input?
Yep, absolutely. So this were not really me. This were the school-based telehealth team. And so sort of step number one is getting buy-in from the community school board, because they have to approve any of these kinds of implementations. Once the school board sees there could be value in it, then it's really getting buy-in from the school nurse and from the administration of the local schools that you want to work with. This is not something you can do remotely. You've got to go and meet people where they are. And so there's a lot of local travel that goes into these activities to build relationships, to build trust. The school-based telehealth program would also offer summer asthma camps to kids in these communities to try to help improve education, knowledge, and management of asthma care. And then ultimately, it comes down to high-quality care delivery. And so once you sort of have that first win where a parent and a child have a good experience, then it's going to be a ripple effect. So it's getting the local leadership to buy into the program and to have trust in the program, and then having those wins with those early patients.
So there's a question: have you engaged residents and medical students in telehealth, and do you have a curriculum for them to participate?
We do. Yes. So prior to the pandemic, the internal medicine residency has their residents engage in a remote patient monitoring program for diabetes. And that's been a really successful program in terms of improving hemoglobin A1C control. And so the residents use that program to help manage their patients with diabetes. And there is a nice curriculum specific to that program. And then with the pandemic onset, Doxy.me offers the ability for the resident to be in the virtual patient room, as well as the supervising attending to be in the virtual patient room. So our ambulatory teaching clinics are using the telehealth tool there for both the resident and the attending to be able to visit the patient in the resident ambulatory clinics. That is a functionality, and it was one of the reasons we chose Doxy.me as compared to some other platforms. The psychiatry residency also has their residents doing telehealth visits. So I would say it does vary by department, but it is certainly kind of there's a lot of uptake in different areas and in different ways that kind of make sense for the particular training programs. As far as things like acute care consults, there's probably less of a role for a resident in that, although the neuro program does use them somewhat. And we also, just broadly speaking at a GME level, are working with the Medical Colleges Association to come up with standards and criteria for how to start integrating GME trainees into telehealth services, because there's a supervising question, there's having trainees, quote, practicing in sites that may not be part of their health system. So there's a fair amount of things that are still left to be figured out in some ways at a national level, but we're definitely contributing to that work as well.
Great. Well, there's a few other questions, but it's 9 a.m. Our time. So I will send you those questions and you can follow up with the participants. But I really wanted to thank you for making the time and presenting us really a wonderful overview and showing what the possibilities are, and how South Carolina has really leveraged the technology to work on addressing healthcare disparities. So
yep.
Thank you again, and we will get you out here soon.
Thank you. Yeah, and I'm more than happy to answer any questions. Just please feel free to provide my email address or whatever, and I'm happy to have dialogue with any of your faculty or trainees that might be on the line about their questions and their ideas. Much appreciated. Have a great day.
Take care. Bye-bye. Thank you, everyone.